Now I will introduce Dr. Ajit Brindhaban, graduated with a PhD from University of Auckland, New Zealand in 1993, worked in radiography for 2 years and taught medical imaging physics in New Zealand. For 6 years, associated professor in radiologic science department at Kuwait University. Area of research interest include radiation dosimetry and imaging protocol optimization. Our lecture now, it's evolving radiation dosimetry in CT. Welcome, Dr. Ajit.
Thank you very much. Thanks for coming along. So today, I thought I'll start with how we do CT dosimetry now and what limitations those quantities have. And Dr. Said talked about CTDI, DLP, and so on. So I just want to go through where we are heading and what we can sort of do. So why we are concerned about doses in CT is that in 1987, about 15% of general population dose came from medical imaging. 20 years later, in 2006, we have 50% of population doses come from medical imaging. And most of that has come due to increase in the amount of CT use. We do a lot more procedures, we do use a lot more radiation, and therefore the population dose is increasing. So we need to look at how we can manage that. So any examination you do using ionizing radiation requires justification, which means that the patient must have more benefits than the risks that you put the patient through when you expose them to ionizing radiation. So CT dose measurements we normally carry out to do various things. So we talk about comparing CT techniques, procedures, different CT scanners, different technologies, reconstruction methods, detector technology, and so on. We also use dose measurements to optimize protocols. So how do we balance the diagnostic image quality with the amount of radiation we use? We also establish diagnostic reference levels, which are sort of dynamic process of improving your optimization. So there are lots of things that we do CT dosimetry for. Epidemiological studies is another sort of reason. But CT, exposes patient in a totally different way to conventional projection imaging. If you look at the depth dose, you start with entrance skin dose at the entrance to the patient to be about 100%. And in radiography, you will go through about, so let me see if this one works. Yeah, okay. So in radiography, you go through about 100% at the entrance, and at the exit, you will only get about 0.1% of the radiation intensity. Whereas in CT, you take projections all the way around, and your dose distribution within the patient works in rings. So you get higher doses around the periphery and slightly lower doses around the middle. Now, how that changes depends on patient sizes and the image acquisition parameters you use. So to give you an idea, so here's an image of the abdomen. So you get the image, then you get the dose distribution, and then you get the anatomical image overlaid over the dose distribution. And you can see what organs get what type of dose or what sort of distribution. So in quantifying CT dosimetry, we look at this dose report. Every patient's image file has a dose report. And in the dose report, they report several things. The two main dosimetry quantities they report are the CTDI volume and the DLP. And what they actually mean and what they actually indicate are sometimes misinterpreted. And therefore, we will figure out what it is and how we actually go about interpreting it. So, CT dosimetry is generally measured. If you worked in CT and done some work, you will know that we use a 10 centimeter long phantom, and we use a 10 centimeter long ionization chamber, and we measure CTDI. And CTDI is normally measured on a 32 centimeter diameter phantom to represent body scans, and 16 for head and pediatric scans. Now, we then come up with a value called the CTDI volume that is displayed in your dose report, and you have the DLP that you also get. When you look at the dose distribution of a single slice acquisition, if you do a 10 millimeter slice, in the ideal world, we would like the radiation dose to expose only that part of your patient's body. But in the real world, you have beam diversion. Your slice thickness is defined at the isocenter. So further away, your slice thickness is much bigger, and therefore your scatter tails expose extra tissue outside your imaging region. And all of that is taken into consideration when we do CTDI volume. So what does CTDI volume indicate? It indicates when we do multiple scans, what is the average multi-scan average dose is, and that sort of is represented as the CT dose index. It only tells you how much radiation your X-ray tube produced, because that's what the phantoms measure, right? If you use a different size phantoms, then you get slight different CTDI values for similar exposure factors. So here, your MAS is only about 50 MAS less, or it's less than about 20%. But your 16 centimeter diameter phantom will measure almost double of what a 32 centimeter diameter phantom would. So when we do report doses, a third important factor you need to look at is what phantom size was used to measure that. And that's a key component of making sure that we know what quantities we are talking about. So if you take a 32 centimeter phantom measurement and you have a patient who is about 25 centimeters in diameter, and your CTDI volume you display is not going to be the same as what the patient actually sees. Because a smaller patient with the same CTDI value would actually receive higher doses than a larger patient. So the CTDI has sort of inherent limitation in terms of that it is only applicable to the size that the phantom that you measured. So if your patient is of a different size, it actually doesn't represent a true picture of what the CTDI volume is. So this is one of the major inherent problem. The other inherent problem now with multi-detector CT scanners, your beam width can be as big as 15 centimeters or 16 centimeters. So you have a 320 detector row CT with each detector row about 0.5 millimeter, you're looking at 16 centimeter beam width. With the 16 centimeter beam width, do we measure CTDI volume with a 10 centimeter long chamber or a 10 centimeter long phantom? So that's another sort of inherent limitation with CTDI volume, the way we measure now with multi-detector CTs. Then the other thing that we also report is a DLP. Now, the DLP is simply your CTDI volume multiplied by the length of the scan. So that is what DLP is. It can be estimated before if you know exactly what the scan length is, but generally it is worked out after the scan is completed. CTDI will be predicted before you do the scan, but DLP generally is calculated afterwards. So DLP is similar to DAP in projection imaging, but that's something different. Now, if you do multiple phases of CT scans of a patient, you can actually add the DLPs to get a total DLP. But CTDIs cannot be added together because it's only an index, as we heard before. So DLPs can be converted to effective doses, but then again, they use conversion factors. The conversion factors are just an average for different size patients, different sexes, different body composition. So that also has an inherent limitation in that one. So CT scanners have evolved over the years. We started with a single slice CT scanner to now we are looking at more than 128 row CT scanners. So the beam width is much wider, and therefore the measurements are not going to be as critical or as clinical as we want it to be. So we have some limitations of CTDI volume and DLP. They're still based on measurements using a 100 millimeter chamber, 100 millimeter phantom, reported as CTDI 100. So dose profiles of if you do a 40 millimeter nominal beam width, say 16 or 32 centimeter, 32 row detector CT with 1.25 millimeter detectors, you get a 40 millimeter beam width. So when you look at a 40 millimeter beam width and if you use a 100 millimeter chamber, it doesn't measure all the scatter tails that you have. And therefore, it will underestimate your CTDI volume if you're covering long distances like 150 millimeters of patient's body. And it'll sort of underestimate if you're doing a short scan of 40 millimeters in length. So these are inherent limitations. The other limitation is it doesn't take into account patient size. So a CTDI volume that you get for a scan applied to this patient is going to be different in terms of patients of these sizes. So there are inherent limitations as we use CTDI volume and DLP now. So where are we heading? What are the alternatives? Earlier we heard about the size-specific dose estimates. So that's the current sort of metric that has been proposed as an alternative to CTDI volume. Again, it also has its own inherent limitations because it actually comes from the CTDI volume we measure. So it's not the best solution, but it's a slightly better solution because it takes into account the patient sizes. So how do we get size-specific dose estimates? Your size-specific dose estimates is just a conversion of your CTDI volume by patient-specific conversion coefficients. So where do we get the conversion coefficients? It's based on the patient sizes. So it could be your AP size or lateral size or a combination of the two. And then there's also what's called the effective diameter that is being used. So these are purely on physical size. It doesn't take into account the tissue composition of the patient. The AAPM recommends using what's called the water equivalent diameter. So what is an equivalent diameter of a phantom that your patient represents? So that is what AAPM recommends is the best size-specific dose estimates would be. So the benefits of this is it accounts for patient size differences and patient composition differences, but it's still based on the CTDI volume. And it actually gets complicated by use of AEC. It also gets complicated by if your patient's anatomy changes rapidly within the scan range. So there are a couple of things that still limitations, but it is probably the best we've got at the moment. So, other alternative is to go and work out organ doses. Now, your CTDI volume converts to DLP, then it converts to effective dose. And the effective dose gives you a single number that we have been using as a risk estimate for patient from that particular radiation exposure. And that allows you to do risk-benefit analysis in general populations. So organ doses are considered to be better measurements. So if we can measure organ doses, that will be the ideal situation. But the problem is it's very difficult to measure organ doses in patients. We may have to use phantoms, we may have to use simulations. It doesn't give us the ability to measure organ doses in patients. So International Commission of Radiological Protection recommends that organ or tissue doses are required to assess probability of cancer induction in exposed individuals. Now I have said that the effective doses may not be as good as we thought it was. So this is an ICRP 103 recommendation, came out in 2007. So organ doses are probably the way to go, but at the moment, we don't have any way of sort of measuring that. There have been studies based on simulations and measurements using post-mortem subjects, but work is still kind of evolving in that respect. Real-time personalized dosimetry is probably the way forward, but to do that, we have to be careful about the equipment that we use. So the patient dose estimates needs to be equipment specific, such as the spectrum of the type of spectrum that X-ray tube produces, the amount of filtration you have, and sort of detector row geometry of the scanners. These have to be taken into account. And it has to also be patient-specific. So we may have to create patient models based on cross-sections. So once we do the cross-sectional imaging, we might be able to do patient modeling. And then it needs to be protocol-specific. It needs to account for all protocol parameters like your pitch, your slice thickness, your kV, your MAS, and so on. And it also must be available real time in the sense that it needs to show soon after your procedure is finished at the latest. So user-friendly software incorporated into CT scanners are required. And we hope we might be able to use artificial intelligence to actually model patients from cross-sectional images or patient tissue characteristics from cross-sectional images and try and overcome the weaknesses we have in current CT dosimetry. So this is just to give you an idea of what we do now and what is being proposed currently and where we may be heading in the future. And thank you very much.